So, a very good afternoon to all of you, and I want to thank Dr. Saurav for making me a part of this interesting IC. And it's very nice to see such a good attendance in the hall since the morning. So, I don't see my presentation on the laptop.
I think you just switch over.
So, retinal hemorrhages and exudates, DR or something else. So, this is a very common fundus picture or the clinical signs that we see in our day-to-day clinic. We see hard exudates, we see the red colored hemorrhages, and the most common thing which comes in our mind, of course, is diabetic retinopathy. So when we are seeing this, we think whether we are dealing with diabetic retinopathy or something else. And yes, this question should come in your mind, and do not assume that every case which presents like this is in fact diabetic retinopathy. So when we diagnose it as diabetic retinopathy, of course, the patient will have in 90% or majority of the cases a history of diabetes, but sometimes you may have an undiagnosed diabetic patient who may be presenting for the first time to you with diminution of vision. So you have to get that patient tested and rule out the presence of diabetes in your patient. Often, diabetic patient will have a bilateral involvement, and of course, there will be presence of other signs which we all are very familiar with, suggestive of either non-proliferative diabetic retinopathy or proliferative diabetic retinopathy in the form of retinal neovascularization, vitreous hemorrhage, tractional retinal detachments, and so many other signs which we have been reading since our post-graduation. The other thing that should come in our mind is hypertensive retinopathy, and of course, here again, majority would have a history of hypertension, but you may be dealing with a small section of patients who may not be aware that they are actually suffering from hypertension. There will be patients when you ask them, do you have hypertension? And they will say, no, we don't have any hypertension. But in fact, they were diagnosed with the hypertension in the past, they were put on treatment, and on their own, they have stopped taking the medication. So basically falling into a non-compliance patient with antihypertensive drugs. And then of course the patients who are not aware of it. So when we are differentiating between hypertensive retinopathy and diabetic retinopathy, there are a few differences that we can keep in mind, that the hemorrhages are going to be few. In hypertensive retinopathy, the edema will be less, fewer exudates, the cotton wool spots are going to be multiple, you'll have more flame-shaped hemorrhages in comparison to dot hemorrhages, and there will be visible abnormal retinal arteries which are going to be involved or having changes. In comparison to DR, where we are going to find multiple hemorrhages, extensive edema, lot of exudation, fewer cotton wool spots, fewer flame-shaped hemorrhages, and we will also be having the involvement of retinal veins and capillaries in comparison to arteries, which are more commonly involved in hypertension. Now, another diagnosis which you can make again is any kind of a venous occlusion. So we have a branch retinal vein occlusion or a central retinal vein occlusion, and again you are going to be having the patients presenting with hemorrhages and exudates. And when you do a fundus fluorescein angiography, you can find these typical capillary non-perfusion areas. And when you do an optical coherence tomography, you would find that the edema is following the vertical line and is going to be restricted more on one side, and the other side is going to appear to be quite normal. And this is a patient with CRVO where that vertical line is not going to be respected. You're going to have edema on both these sides. And these patients, of course, are going to be presenting with more extensive capillary non-perfusion areas, more extensive hemorrhages, more diminution of vision. And on OCT, they can present with cystoid macular edema accompanied with neurosensory detachment. Macular BRVO is another entity which we should keep in mind, where you will have a very small section of the macular area involved with hemorrhages and with exudates. And very classically, when you're going to do a fundus fluorescein angiography, you will find that there is this diffuse leakage which is limited to a very small area in the macula. And again, you can very much keep this in the differential diagnosis of hemorrhages and exudates in the macular area. Now, IJFT is another diagnosis or a differential diagnosis when you are seeing a patient with hemorrhages and with exudation. And how do you diagnose it? You will have a subtle whitening around the foveal area, which is very well appreciated when you do an indirect ophthalmoscopy. And when you do a fundus fluorescein angiography, you will find that there is this capillary leakage, which is going to be surrounding the fovea. So this again is very classically found, and sometimes we may misdiagnose it as a diabetic retinopathy because there is a more occurrence of IGFT in patients who are having diabetes. Now, this is another picture where you are finding exudation, you're finding hemorrhages, but you're also finding something like a very extensive subretinal hemorrhage covering the entire macular area. So this is a patient having retinal arterial macroaneurysms, and when you do a fundus fluorescein angiography, you are finding that there is hemorrhage, which is very much there in the subretinal space. But this is an entity which can have hemorrhage at various levels. It can be subhyaloid hemorrhage, vitreous hemorrhage, retinal hemorrhage, subretinal hemorrhage. So it is a good idea where you can do a fundus fluorescein angiography and you can identify these macroaneurysms and subsequently treat them with laser photocoagulation. So this is one patient where we went ahead, gave an anti-VEGF and focal laser, and you find that there is a beautiful regression of the macroaneurysms and quite a good clearance of all the edema and the exudation. Now, this is another differential diagnosis where we have an elderly patient, 60 years old female patient with complaints of reading vision problem for last 2 months. And in the right eye, you have multiple soft confluent drusen's. Now, this is a very typical diagnosis, which we all see in our day-to-day clinic, where you are having some membrane-ish kind of lesion in the central area. You have hemorrhages, you have drusen's, and you have a lot of other things such as on this photo you may not appreciate, but they can be a presence of subretinal fluid pocket also. And when you do an OCTA, you can find this neovascular network. And when you do a OCT, you may find this bumpy appearance of the RPE with an occult CNVM and also having an accompanying pocket of subretinal fluid. So this is a typical diagnosis of choroidal neovascular membrane. Here, of course, it's secondary to AMD, but you can have it secondary to multiple other causes, which I'm not going to get into the details. And these patients, of course, would need an urgent anti-VEGF treatment. Now, this is a 45-year-old female patient with a history of fever 2 months back. And what you find is, and apparently she was a mother of a doctor who was doing her post-graduation, and she was very troubled because she said, my mother just had a viral fever and I don't know why she's having a drop of vision. So what you see is hard exudates again, which is like in a fan shape. You see cotton wool spots. You again see a lot of hemorrhages. Now, please don't confuse this because this patient was a diabetic, but you have to learn to differentiate the fundus picture that it is not a diabetic retinopathy. You don't see the typical features of a diabetic retinopathy over here. So we did an OCT and this is how it looked. The investigations were ordered and including a Weil-Felix test which came out to be reactive. So both eyes we diagnosed it as a fever retinitis patient and the patient was put on prednisolone along with doxycycline. And both the treatments were started simultaneously. And this is how the patient responded. She came with a 1/60 vision to us, 6/60 and 36 vision. And this is the timeline. After 1 week, she had improved to 636, 624. And after 2 weeks, she had improved to 618 and 18. And you see that there's a beautiful resolution of all the lesions. The left eye also responded very well to the treatment. This is my favorite topic, a 21-year-old girl. Sudden painful diminution of vision in the left eye for last 10 days. She had a history of typhoid fever 2 months back, which again is a misleading history. The right eye was absolutely normal and the left eye had a vision of counting finger close to face. And this is how the fundus picture was in the left eye, where you do find some element of vasculitis. There is a yellowish lesion sitting on the optic nerve head with a large lesion sitting in the macular area with these typical hemorrhages, what you are seeing overlying this huge granuloma. And this again is very classical of a tubercular granuloma. And when you do an OCT, you are able to appreciate a huge choroidal bump suggestive of a tubercular granuloma with an accompanying pocket of subretinal fluid. So these are the various things that you have to keep in mind, and this is a very exhaustive list of all the differential diagnoses that should run through your mind. But I think you have to be very selective, keeping the entire picture of the patient and then coming down to at least 4 to 5 differential diagnoses when you are seeing a patient with retinal hemorrhages and exudates. So I would just conclude my talk by saying that retinal hemorrhages and exudates may be secondary to multiple etiologies. A detailed history-taking, clinical examination, both systemic and ocular, tailored lab investigations all together help us unravel the underlying cause of exudates and retinal hemorrhages. So keep all these factors in mind. Thank you so much.